Well, thank you so much, Molly, and good afternoon, everyone, and welcome to today's Integrative Nursing webinar hosted by the University of Minnesota's Earl Bakken Center for Spirituality and Healing. I'm Dr. Mary Jo Kreitzer, the founder and director of the center and the lead of the Doctorate of Nursing Practice specialty in Integrative Health and Healing in the university's School of Nursing. Throughout the center's history, we have worked in support of health professionals, including integrative nurses. We are very excited to be hosting as our speaker today, Jane McCampbell Stuart, who will share a presentation titled Bad Stuff, Trauma, and PTSD, How COVID Blew the Lid Off It All. I love the title of Jane's presentation. A little bit of context around integrative nursing. Integrative nursing is a way of being, doing, and knowing that advances the health and well-being of persons, families, and communities through caring, healing relationships. Integrative nurses use evidence to inform traditional and emerging interventions that support whole person, whole systems healing. As I think everybody on this call recognizes, the COVID-19 pandemic has had a devastating impact on people around the world, and it's been particularly hard on healthcare professionals. The well-being of the healthcare workforce has been seriously compromised, as evidenced by soaring rates of stress, anxiety, depression, and early exit from the profession. We know that trauma and PTSD are realities that will impact the health professions for years, for decades actually, to come. One of the principles of integrative nursing focuses on the health and well-being of caregivers as well as those they serve. It's hard to give what you don't have. A little bit about our speaker today. Jane McCampbell Stuart is a licensed therapist, a certified coach, and a certified Akashic healer, specializing in the treatment of trauma and PTSD. Jane has worked with thousands of clients with trauma stemming from prenatal to adult, covering attachment, physical, sexual, and emotional trauma, medical and childbirth trauma, accidents, injuries, and other traumatic losses and events. She received her master's degree in marriage and family therapy from Bethel Seminary in Minnesota, where she later served as a faculty associate and the department's expert on trauma. Jane will speak for about 45 minutes, and then, as Molly said, you're invited to put your questions in the Q&A box, and we will have Jane answer as many questions as possible. So welcome, Jane.
Thank you so much, Mary Jo, for that kind introduction, and welcome to everybody to Bad Stuff, Trauma, and PTSD, How COVID Blew the Lid Off It All. As Mary Jo said, I am Jane McCampbell Stuart, and I am a licensed therapist, and I'm also a certified coach. But more recently, I've been referring to myself as an integrative trauma healer. And the reason for this is not only because I blend a number of different healing modalities depending on the issue that I'm working with and the client who's come in, but mostly because I believe that trauma needs to be elevated beyond the mental health space. And the reason for that is when we're treating trauma, we're not just treating the mind, but we're also treating the body and we're treating the soul. Now, I know I'm really preaching to the choir with this audience here, which is beautiful. And the impact of trauma on the body has been really well documented. So perhaps the most famous textbook on trauma available right now is Bessel van der Kolk's book, The Body Keeps the Score, which is standard reading for anybody wanting to know a little bit more about trauma. But when we're working with trauma, we're also working with people who have had a brush with death, which means that we then need to address their spirituality and take care of their soul. And that is the piece where this needs to be completely integrative of mind, body, and soul, and why I'm so delighted to be able to share some of this information with you all today, because all of you really get it, and this is the space where you work. So there are some continuing education credits available for today's presentation. And so that means that we do need to give you some objectives, and I will try and highlight the points in the presentation when we get to these objectives so that you know that you've met them. The first one is to identify the differences between covert trauma, overt trauma, and PTSD. And I put these out there just because there's a lot of parlance or wording that gets bandied around in the trauma space. I've even started hearing PTSD used a little bit like people use OCD. So, oh, that's just my PTSD. And I think it's really important when we're in the space that we are, that we can really recognize it and know what it does mean for somebody to have PTSD, and to be able to differentiate that from other traumatic reactions that we might observe. The second thing I'm hoping you take away from today is to be able to describe the hallmarks of a traumatic reaction and then how to respond when you encounter one. And again, the reason for this is that trauma is so often missed. I will talk a bit more about that further along. But if we can recognize something as a traumatic reaction and then respond, we can be more helpful to ourselves and to the client or the patient that we're working with. And then the final objective today, I've actually already alluded to on the previous slide. This is to name the most vital component of any successful trauma treatment. And the answer right here is to pay attention to the body. So again, the way that trauma gets stored in the body is documented throughout the trauma literature. And what that means is that standard talk therapy is not going to cut it. And I do later on have a list of the different therapies, and there are more that will pay attention to trauma, but it's really, really important that anytime you're treating trauma or suggesting to somebody that they go and get treatment for trauma, that the work includes the impact on the body. So I thought we'd just start by my sharing a little bit of the history of trauma as a recognized mental health disorder. And in the whole mental health field is actually relatively new. It didn't make it into the Diagnostic and Statistical Manual until 1980, which is actually pretty new as far as disorders go. And it's historically been associated with war veterans. What used to be called shell shock among veterans in the First and Second World War became to be known as PTSD. And my personal opinion on this, which is of course a little bit political and controversial, is that it's associated with war veterans because this is the first time that the phenomenon of trauma was first recognized in a predominantly white male population. Now, of course, women and children and people of color have been experiencing and coping with the impact of trauma for thousands and thousands and thousands of generations. So in that sense, what we're seeing now is not new in terms of the trauma that's there. What's new is that we're finally recognizing it and we are able to be talking about it. So when you see it everywhere and that sometimes feels overwhelming, it's also really helpful because if we talk about it and we can see it, we can name it, and then we can heal it. So we've seen these big societal and also political shifts just going on in the past 2 years, particularly since the onset of Me Too. That was a big one. All of the Black Lives Matter work in the aftermath of George Floyd and others, that has really opened up so much debate and discussion around trauma, which is a good thing. And I also want to give a shout out to the medical shifts that have happened. So particularly in neurobiology research, there's some really beautiful research looking at the impact of trauma on the brain, and then also the epigenetic impact of trauma and how it comes down the generational line. And what that means is that society and politics as a whole are finally recognizing the pervasiveness of trauma and how it underlies so many other physical and mental health concerns. The really baffling thing to me, however, is that it is still frequently misdiagnosed as depression, as anxiety, and as ADHD. And there are some reasons for that. There are a lot of symptoms that look similar, and those issues can actually be co-occurring. But it is amazing to me, even people who have been in therapy for many, many years, who come to me and they've never had what's going on for them named as trauma. And actually, a lot of the clients that I am getting these days have been referred to me by integrative health professionals who have been treating the client for symptoms like IBS or fibromyalgia or other things that typically don't slot nicely into a medical diagnosis. And they're the ones, it's the herbalists, the homeopaths, the acupuncturists who are spotting the trauma and then being able to say, yeah, this is treatable. And the beauty is, and this is one thing that I really want to get out there, is that trauma, once it's recognized, is highly, highly treatable. And that's not something that has been fully understood. Certainly with the veteran narrative, everybody felt once you had it, that was just it. We could manage the symptoms. But actually, when we recognize it and when we treat it well, we can heal it. And we can also build more resilience from it. So there's beautiful research that shows when trauma treatment is done in a safe place, for example, in a ceasefire, then once the people go back into the stressful situation, they have a lot more resilience to be able to deal with it second time round. So what is trauma at its core? The way I describe it is basically about powerlessness. So trauma is really the experience of abject powerlessness when something is threatening to our life or our sense of integrity, or it's threatening to somebody else's life or sense of integrity, and we are witnessing it, but we are completely powerless to be able to do anything about it. It's a really basic primal need to be able to impact our environment, to be able to speak and have somebody listen when we call and look where we point. And when we are completely powerless, that is taking away that most basic primal need that we have. And that is really underneath trauma. And then what happens when we've experienced something traumatic is that it causes us to live as though whatever happened is still happening now or could happen again at any moment. So this leads me to my description of trauma, which is that it is basically a disorder of time and place, where the reaction that we're having in the present is being informed by whatever happened in the past. So this leads us to another vital component of trauma treatment. So in addition to paying attention to the body, another vital component of trauma treatment is actually helping the client distinguish the past from the present. So yes, you were really unsafe in that moment in the past. Is that lack of safety still the same now? One of the ways that I do this is by working with clients to help them find a beginning, a middle, and an end to the story. And while clients might have the beginning, and they definitely have the middle, it's often the end that is missing. So in the worst part of that traumatic event, the brain goes into some kind of shutdown. It goes into a fight, flight, or freeze response. We dissociate, we leave our bodies, we do something to be able to just preserve whatever bit of integrity of our soul that we have left. And so the brain that is responsible for processing and making sense of everything that's happened never actually knows what the end of the story was. And so sometimes the work is just actually helping the client realize the fact that you are here with me right now in this present moment means that this is not still going on. So let's pick up from the moment that you remember where this left off so that you can know that there was an end to whatever happened. One of the analogies I like to use with my clients and students is the broken wine glass analogy when I'm explaining trauma. So if you imagine dropping a wine glass on a tile floor, all of the pieces are going to go all over the floor. And you don't know where they've gone. So the first thing that you need to do to deal with it safely is hopefully to put on a pair of shoes. And then you're going to grab a broom and you're going to start sweeping. And you're going to sweep from all of the corners of the room because you don't know where those pieces of wine glass are. And as you do that, you might find there's some Lego bricks and some cat hair and goodness knows what else has been under your refrigerator all of this time. But once you've swept everything, you're then going to do this mental check to make sure that you can mentally rebuild the wine glass in your mind. And then you know that you are not in danger of stepping on a piece of glass tomorrow morning when you come down for breakfast. Trauma does a similar thing. All of the sights and sounds and body sensations and everything that we associate with that event go, and they all get stored in these different parts of the brain. And if we don't do the work of going around and sweeping all of those parts up and bringing them all into one place, then all of those little shards of memory are in danger of becoming triggers that can later be stepped on and cause symptoms to arise. That is trauma in a nutshell. What I then want to just go on and talk to you about, and this is one of the other objectives that was in there, which is the terminology of overt versus covert trauma, which I just want to make sure that everybody is able to understand. Obviously, when you're treating trauma, there's going to be a difference between overt trauma, which is going to be a specific, discrete, definable event or situation. So this is going to be the physical assault, the sexual assault, the car crash, the hurricane, whatever happened to make you unsafe in that specific event, that period of time, the school shooting, the bridge collapse, all of those things where your brush with death happened and your life flashed before your eyes and you weren't sure whether life was going to be the same again. On the other hand, we've got covert trauma, and covert trauma is the much more pervasive, persistently stressful situations that happen over time. So these are the kind of situations that you would see discussed in the CDC ACEs study, the Adverse Child Experiences study, that actually found that 61% of us have at least one ACE. And that with this covert trauma, this is where we're living in a place that's constantly stressful. So watching a parent be abused, watching a sibling be abused, being abused ourselves, having a parent who is addicted to drugs or alcohol, living in a war zone, being born into a country at a time of war. I deal with a lot of patients on that. Those persistently stressful situations where the cortisol levels are high, the adrenaline levels are really high, and it's really hard for us to know when are we safe in the in-between. Now, you might have heard this overt versus covert trauma described in another way, which is the language of big T and little t trauma. And big T and little t trauma is just pervasive throughout the trauma literature. So you're going to see it, you're going to come across it, but I really struggle with it. And this is for a couple of reasons. The first one is that it's really invalidating, because people feel that when you describe their trauma as little t, that it's actually not as big, it's not worthy of the reactions that they're having. I'm in a social media group for EMDR, and there's a number of EMDR therapists on there, as well as clients who are starting EMDR. And the biggest complaint that I see from clients again and again is that where they feel that their trauma was invalidated because it was described in this little t language. The other thing about little t versus big T is it is really misleading, because it's much more straightforward to treat an overt trauma than it is to treat that covert, pervasive, persistent trauma. It's a little bit like being in the medical field. It's probably much easier to treat a straightforward break or a wound than it is to treat a lymphoma or fibromyalgia or something that is much more chronic. And it's kind of the same with trauma. So this is on your objectives, so you can screen grab this slide if you need to, and just wanted to make sure that everybody was really clear about that. So we've talked about what trauma is and how it occurs. So how do we go about spotting a traumatic reaction? Well, there's a really useful rule of thumb here. And the rule of thumb is that when the reaction is out of proportion to the issue at hand. So that means you've got a reaction that is way too big. It's really shrill, it's really angry, it's really defiant or really fearful. I was talking to a nurse yesterday who was working on a COVID ward, and she told me about a patient who came and said, "You're not going to," expletive, "intubate me." And of course, the response to that could be, "Well, thank you." Or it could be a response that says, I get it. This is really scary. I get why intubation is really scary. Or we can have a reaction that is the opposite way. The reaction where something is denied, it's ignored, it's belittled, it's tucked away. It should be a bigger issue than it is, and we're not looking at it. Or it could be a reaction that is just really, really confusing. And I want to spend a moment to talk about confusing for a minute, because typically what happens when we encounter something confusing is we assume we must have missed something. And that if we say something, then we expose the fact that we've missed something and we might look a little bit stupid. And so we don't. We just think, okay, that's confusing, and I'll go and look it up or check on it later or ask somebody else if I missed something. But we assume we're in the wrong. So what I'm constantly telling my clients and my students is if it looks confusing, if it feels confusing, it probably is confusing. And confusing is a valid emotion. And it's something that you can notice and go, oh, that is really confusing to me. Is it a little confusing to you too? Okay. So that's the basic rule of thumb for spotting a traumatic reaction, when the reaction is out of proportion to the issue at hand. And if you remember what we said before, it's because we might be responding to something in the past rather than something that is in the present. So clues that you might be seeing a traumatic reaction. So denial or minimization. If you cast your mind back to your 101 nursing, you probably did Elizabeth Kubler-Ross's stages of grief. And you'll remember that the first stage of grief is denial. And denial is actually really important to our survival. Denial allows us time to absorb the shock. Denial allows us time to be able to get out of bed and make the kids breakfast and get them off to school and pay the rent, even when something huge has happened. Denial allows us to carry on existing in childhood when we're in an impossibly stressful situation, or when physical abuse, sexual abuse, or violence is happening. It allows us to get on and do what we need to do until we are in a safe enough place to be able to deal with it. The problem with denial comes when we let it go on too long, when we're no longer in need of it, we're no longer in that situation where we need it to protect ourselves, and then we're ready to heal it. Because then it's going to show up in a whole bunch of different ways, and very often it's actually going to show up in the body. So the body will manifest what the mind will not. And so denial is a really important thing to pay attention to. Uncontrolled fear, anxiety, panic, living in a constant state of hypervigilance, that is usually going to be some kind of traumatic reaction we want to pay attention to. And this is where we're thinking, okay, is the fear actually appropriate for this precise moment, or is it being informed by something else? Shrillness of tone. This is something I see all the time over social media. And it's typically something where somebody has one big hot button issue that they get very, very shrill about, but they're not as shrill about other issues. So whether that's about abortion, or whether it's about racial justice, or whether it's about politics, or when there's one specific issue that they're especially shrill on and not shrill on other things, because we do need to get outraged and upset by a lot of what's going on, but when there's one specific thing that's standing out as being really shrill, it's worth looking and saying, oh, maybe there's a little bit of trauma there. I wonder what that is about. And then there is this issue of increasingly desperate attempts to try and control one's environment and everyone in it. So the joke that I make is that traumatic reactions are incredibly boundaryless. So instead of managing ourselves and managing our own nervous system and our own response, what we try and do is manage our environment and everybody in it. And so we can see this with an obsessive need for information, which actually just increases anxiety. It doesn't bring it down. We see it with obsessive cleanliness. We saw that at the beginning of COVID, right? Washing down the groceries as they came into the home. And then we see it in obsession over whether others are abiding by the rules. All of these things are desperate attempts to make one's environment safe, and usually come out of having been really unsafe in another place and time. So those are all traumatic reactions that we might see at any time. So how do we spot something that is not just a traumatic reaction, but it is actually PTSD? And the easy rule of thumb with PTSD is going to be the existence of nightmares and flashbacks. And nightmares and flashbacks are basically a way of the brain trying to relive the event, to do that work of sweeping up all of the pieces of the wine glass to be able to make sense of it so that it can put it away. Now, it's important to remember that this is unwanted or involuntary reliving of the event. So this is not the rumination where we go round and round and replay conversations in our head. This is when they force their way in, usually when the mind's at rest, or when we're having a nice time, or when we're asleep and we can't move in and shut it down. Nightmares and flashbacks are often the most disturbing issue to the client, and often clients feel incredibly ashamed and weak that they have them. Paradoxically, however, it's the most straightforward of any trauma symptom to treat. When I was a really brand new therapist, one of my very early clients was a veteran, and I just met him a couple of times, and I got an email saying, I have just slept through the night for the first time in 8 years. Thank you. The hardest part of treatment is getting the client through the door in the first place, because they're so awful that we want to just shut them down. We don't want to address them. We just want to be able to put them away. So when I'm on this, I also just want to note, and this is not in the handouts that you have, I just added this yesterday. I do want to let you know that there is a drug there, an alpha blocker drug that's prescribed for high blood pressure called Prazosin, that has also had a lot of success in reducing nightmares. And so sometimes when you've got somebody in just such a bad state that they're not even getting any sleep, we need them to get to sleep first before we can treat anything. And so one option might be just to get some Prazosin prescribed for them, provided that they don't have any glaucoma or any high blood pressure issues, any low blood pressure issues, sorry. Prazosin could be an option that can just help them be able to sleep through the night without being disturbed through those nightmares. Possible additional symptoms that happen, so other sleep disturbances, that's always the first thing that I pay attention to. If the client is not sleeping, I need to get them to sleep, because I can't figure out what's trauma, what's anxiety, what's anything else if they're not sleeping. So busy brain, needing the TV or radio on to get to sleep, that's a big clue. And then twilight jerks. So twilight jerks, when we're just dropping off to sleep and we're just in that little bit of sleep between dreaming and wakefulness, and then suddenly we dream that we've fallen downstairs, or there's a ball about to come and hit us on the head, and we jerk right awake. And that's often because as the brain is traveling around making sense of everything that's happened in the day, it runs into one of those shards of glass and it doesn't know what to do with it, so it wakes us up. Other symptoms, so that hypervigilance, constantly just living in the cognitive brain, not letting our limbic system do what it's really good at to do by itself. Distractedness and dissociation, so people who can't stop talking, people who can't sit still, this is why it looks like ADHD, people who are always on the move, big workaholics, blah, 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 and then you wonder why they can't sleep. So again, sometimes it's because they're avoiding some trauma. Minimizing. This event was no big deal. I'm strong, really, it's not that bad, said just about every client ever. Most people come in with some idea of what PTSD looks like, and they're really stunned when it gets named as trauma. So again, it just gets associated with so much weakness, which really is not the case. Sudden emotional reactivity, again, as I said earlier, upset out of proportion to the current event. Unexplained physiological reactivity, so hives, rashes, panic attacks. Everybody thinks that panic attacks come out of the blue. No, they do not. The clues are there if we can learn how to listen to them and spot them. And the other thing that's really interesting about panic attacks is that they mimic a heart attack, because we have been socialized to pay attention to heart attack symptoms. And the brain is going to manifest in the body whatever we're not attending to that we need to. And so very often when somebody comes in thinking they're having a heart attack and find that they're having a panic attack, there's a lot of anxiety and undealt with trauma that's underneath that. And then the multiple somatic complaints, often the ones that end up in the integrative care office. So things like fibromyalgia, chronic fatigue syndrome, IBS, irritable bowel syndrome, a big anxiety trauma issue. UTIs, urinary tract infections, I pay huge attention to them, particularly if the client had them as a child, very often about anxiety. And even if they're not about anxiety, just the process of having to get them seen to and the shame involved in going to the doctor's office for an issue like that, there's going to be some medical trauma there too. Some allergies, skin complaints, and sometimes even asthma can have a trauma component. What should be on there and is not are migraines. Again, migraines, huge trauma and anxiety trigger. So sometimes treating the trauma will help reduce all of these symptoms, which can be really helpful. And then this final one, which is a lack of joy or a sense of foreshortened future, not to be confused with suicidality, but just this piece of just that there's no way to laugh or to find anything funny, or if there is anything funny, it's just that really black, dark humor. That might suggest there's some trauma there too. Now, one of the key things that I've been leading up to in this session is that not all traumatic events lead to traumatic reactions. I'm going to say this again because it's really important. Not all traumatic events lead to traumatic reactions. And in fact, most don't. How can this be? What this is what I refer to as the rule of two. And the rule of two basically says that the first time something bad happens, we're actually really good at being able to put it in its time and place and say, that was really awful, but it was specific to that time and place, to that event. And I don't generally have to worry about it happening every day to me now. The curious thing then is that it can stay hidden, stay embedded for many years. That shard of glass can maybe just sort of stay in the head and nobody's stuck on it, nobody's tripped on it and nothing's reminded us of it until the second thing comes along. And it's the second thing that looks like, sounds like, smells like, feels like that first thing that happened, and the brain says, oh, shoot. That thing that happened was not an isolated experience. It could now happen anytime, and now enter all of my symptoms of trauma and anxiety and hypervigilance. So generally when my clients come in to see me in response to something that has just happened and they've got all of these trauma symptoms, I pretty much know that yes, this thing that just happened was traumatic, but it's being informed by whatever happened before that they might not even be aware of. And this is also really interesting, and much of the discussion that we used to hear about false memory syndrome, or when victims just get raked over the coals in the justice system because they didn't say anything about it at the time. Well, you know what? They put it away at the time, and sometimes it didn't get woken up until later on. So it's really important to understand that the rule of two, traumatic experiences generally occur when a new experience wakes up that previously dormant traumatic experience. So why is this important to us? Well, here enters COVID. In short, where everybody's number twos hit the fan at the same time. Everybody who had ever had difficulty breathing, everybody who'd had medical trauma, everybody who'd had near misses or brushes with death, anybody who'd had unprocessed grief or loss, anybody who felt guilt over grief or loss, not being able to be there when somebody died, anybody who'd had abusive or neglectful parenting, anybody who had had incompetent, abusive, intrusive authority figures who failed to keep them safe. Anybody who had anything on the adverse childhood experiences scale, which, as I said before, is 61% of us, and I've just put the citation for that study in there. Everybody who had any of those things, and way more than I even had room to mention on the slide, has had their trauma woken up. So if you're thinking there is trauma everywhere and it's overwhelming, you are right. It is everywhere, and it is overwhelming, because everybody had it woken up at the same time. So we're not just dealing with a virus, we know how to treat a virus. We're dealing with a worldwide pandemic of trauma, while everybody's trauma has been woken up, including our own. And this has been a really unprecedented time for therapists and for healthcare professionals, because generally, particularly me as a trauma therapist, I'm working with other people's trauma when I'm not going through my own trauma at the same time. With the pandemic, we often are experiencing our own traumatic reactions at the same time as our clients and our patients. So now, what are we going to do about it? Well, as I keep saying, trauma is unbelievably fixable. The way that we fix trauma is a simple two-stage process. The first thing that we do is we name it, and the second thing is that we meet it with compassion. And I'm going to show you how to do that right now. Compassion is the antidote to trauma. So if you imagine picking up a little baby who is distressed, if you're all distressed yourself, the baby's going to get all distressed too, and the two of you are going to go blah, 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 and we just got a mess, right? Now, if your baby is crying and you are able to calm yourself and say, oh, pick the baby up. It's all right, honey. It's okay. What happens is that the baby's nervous system responds to your nervous system. That compassion you have for this child helps soothe their nervous system, and that's how they learn to self-soothe. And there's a lot of people who didn't get that as babies, as infants, and they still need that compassion. Even if we did get it as infants, we still need that compassion. So being able to step into our heart space, calm the nervous system, and meet the other person in that space of compassion is going to be an incredible antidote to traumatic reactions. So I'm going to teach you a basic tapping protocol. So this is the emotional freedom technique. And we're just going to tap on one point. So I want you all to just pick up your left hand here. All right, and we're going to tap on it with the right hand like that. If you'd like to, you can do it this way. Sometimes if we go on too long, that ends up really hurting. So we don't always want to do that, but you can do it this way. All right, and the basic protocol goes like this. And so I'm just going to have you say it out loud with me because none of you have your mics on. And I've given some examples, and then we'll give some space for what is unique for you. So the protocol goes like this. Even though it's been a really tough day, I am willing to hold myself in compassion. Even though perhaps I lost a patient today, I am willing to hold myself in compassion. Even though I didn't sleep last night, I am willing to hold myself in compassion. Even though I yelled at the kids when I came in and then fell apart, I am willing to hold myself in compassion. So we're going to keep going, and you're just going to name out loud whatever is true for you. Okay? Even though I am willing to hold myself in compassion. Even though I am willing to hold myself in compassion. Even though I am willing to hold myself in compassion. Even though I am willing to hold myself in compassion. And as you do this, you might just notice that some tears come up. You just feel it heavily in your body. And that is just the body releasing what you've been holding. Better out than in. So you just keep going until you've named everything that you need to name. That's that acknowledgement. That's that naming it and meeting it with compassion. And then when you've named everything, you say, and I give myself permission to take a break. I give myself permission to be kind to myself. I give myself permission to have a bubble bath and a glass of wine and a whole bar of chocolate. I give myself permission to hold myself and all that has happened today with compassion. The simplest little protocol of naming and meeting with compassion that you can do for yourself, you can do for your kids, you can do for your patients. We also talked about heart space, dropping into that place of heart space and then being able to meet somebody else in the heart space. If you want to learn more about that, there's this wonderful organization called HeartMath. You can find them at heartmath.com. Read all of their research, read all of the way they work. It's really fascinating, but it talks about how we can train ourselves in heart coherence. And once we've trained ourselves in doing that, not only does it make ourselves more resilient, but when we walk into a room, we can actually impact the heart rates of the others that are in the room with us. And they have two little devices that you can purchase, make great gifts if you're looking for any holiday shopping. This is the M-Wave here, and I've used this in my practice for years. I love it with clients. This is the older version, and then there's this new little version here, which is called the Inner Balance device. And this hooks up to your phone and a really fun app. But both of these are really helpful for being able to bring yourself into heart coherence, which is about resting the body, bringing it down, being able to attend to what needs to be attended to in yourself, and then be able to be one of those folk that you can walk into the room and everybody goes, ah, because your heart is coherent and in the right place. So that's heartmath.com. I really encourage you to check that out. I don't have time to go through this now, but safe when you are safe. This is a little meditation I have on my website. It's also on YouTube. The links are there and they'll be available at the end of the seminar. This is when you have to be constantly on, responding, to notice those moments in between, even if it's just the moment when you get to run to the bathroom, when you are safe and you can just let the body rest in the in-between. So you can go check out that little meditation that I have on there that came out of the EMDR world. I would also really encourage you, if you recognize trauma in yourself, get it seen to. Firstly, because it's fixable, but secondly, because it will make you so much more resilient on the other side. And there's a lot of research to be able to back that up. If you do get it seen to, just remember that third course objective, make sure the process pays attention to the body as well as the brain. So EMDR, any form of tapping. So we did EFT today. There's also TFT, somatic experiencing, brain spotting, the accelerated resolution technique, energy psychology, which is meridian and chakra techniques. And there are probably plenty of others that I haven't put on there, but just make sure that the body is being attended to as well as the brain. If you want to learn how to treat trauma in your existing work and you don't have the time and energy and money to drop everything and go back to school and get a mental health degree, go and get yourself trained in the emotional freedom technique. It really is the absolute biggest bang for the buck. And I've put 2 links on there. One is EFTuniverse.com. That is Dawson Church's organization. If you read his book, Mind to Matter, that is there. The other is at energypsych.org. This is the the Association for Comprehensive Energy Psychology, which is a wonderful cross-disciplinary organization of medical professionals and therapists and coaches and acupuncturists and chiropractors and nurses and anybody who works in this integrative space. And it's a really beautiful way to learn how to be able to come together with people from all over the world. So you can check in on that. The membership is really cheap. They have some amazing trainings and a simply incredible conference. So if you're looking to be able to get together with like-minded professionals in adjoining disciplines, this is going to be your place. Books that you can read, I already mentioned Bessel's Body Keeps the Score. I'd also really suggest you read My Grandmother's Hands. This is by Resmaa Menakem. This is really important about understanding racial trauma and its impact in our bodies. And then this one, which is in my engine room right now, It Didn't Start With You, which is by Mark Wolin. And it talks about that ancestral trauma that comes down the generational line and how we can be unconsciously playing out those patterns of our family. Again, a really great read. There's some superb other books out there too. These are just the 3 that I think are the best, with the exception of one, which is this one, Harry Potter and the Prisoner of Azkaban. This is book 3 in the Harry Potter series. It will tell you everything you need to know about recognizing and treating trauma. Go sneak it off your kid's bookshelf and read it at night with this new trauma lens and with everything you've learned today. Thank you so much for your attention, for bringing me into your circle, for letting me work with you alongside these like-minded professionals. It is beautiful work you're doing. Go be blessed in the world in all you do. Thank you.
Well, thank you so much, Jane. This was an amazing presentation, and as expected, lots of wonderful questions have come in. One question I'm just going to kick off and start with is many people that are on the webinar today, work on the front lines, as nurses. And the question is, what are some ways to screen for trauma? Are there some simple ways to begin to just, ask some questions to, surface some of the issues?
So if you're screening for it, the first thing I ask about is sleep disturbances, and I ask about nightmares and flashbacks or intrusive memories. That is the number 1 trauma screener. And then I dig more into other sleep disturbances. So that's usually what tells me is going on. The other way is if you encounter one of those big reactions, you know, like I mentioned with the nurse I spoke to yesterday, and the guy said, "You're not going to intubate me." If you can meet that and be able to say, "Yeah, it's really scary getting intubated. Has that ever happened to you before?"
Mhm.
Then you're eliciting a little bit of that history of, okay, what does this feel like for you? What does this remind you of? And then sometimes all they need to do is name the connection, and that can be enough.
Oh, that's very helpful, Jane. So another nurse writes, could you address vicarious trauma with thoughts for nurses on protectively caring for themselves while caring for others, with the understanding that the psychological trauma exists in the workplace with very little time for recovery in our systems?
Yeah. So it used to be in the DSM that vicarious trauma was actually a separate diagnosis from PTSD. Go figure. They now actually do come under the same heading. So yes, absolutely, vicarious trauma is totally a thing, and it's really important to get it taken care of. I would also suggest if you can get it taken care of sooner rather than later, so before the memory fully consolidates in the brain, it will actually be much better for you and for your long-term resilience. So a couple of the ways that you can do that. So I gave you some of the tapping protocols. I've got other tapping videos on my website. Even if you just go on to one of those tapping sequences and run through it, I have a 10-minute one with instructions. And you hold the worst part of that incident in your mind and you run through it. And that helps the brain and the body to be able to integrate the experience that's just happened, and then gives you the ability to go out and go, okay, that is now put away and now I can move on. And I'd also just say, you know what, get a therapist on speed dial. Have somebody to talk to about it. You know, don't carry it by yourself. Don't take it home by yourself. Talk to a colleague about it, debrief it. And yeah, there's no shame in having a therapist and just calling them up and saying, okay, this thing happened last night and I need it gone. Can you do it? Absolutely, yes, I can.
So a question about tapping. Somebody writes, as I was tapping my wrist, I found myself getting anxious. Is this normal?
And so I suspect probably what was going on for this person is that they tapped into a bunch of stuff that they were holding that has been sitting there unaddressed, that they were unaware had been unaddressed. And it was coming up saying, oh, goody, she's noticing me, or he's noticing me. And wanting then to be able to say, yes, let's deal with it. So I would say hold that in compassion, recognize there's a lot of stuff to be anxious about. And if you want to go share it with somebody and have somebody help you work through it, absolutely do that.
So somebody else writes, Jane, that you mentioned it was important to help clients identify the beginning, the middle, and the end of a traumatic event. So to get in touch with the story. What do you do when you're working with someone who is currently experiencing covert traumatic experiences?
Yeah, that's much more difficult with the beginning, the middle, and the end. There's two answers to that question. So generally, if they've got the covert experiences, the covert experience is not going to be what brought them in. It's going to be the second event that brought them in. So for example, at the beginning of COVID, it was people who had had some medical trauma as a child, but they didn't know that was why they were so fearful of COVID and thinking, what if I catch it now? So in that sense, you're going to deal with what initially brought them in, and then you're going to do the work of, okay, let's see where this got triggered. And even if they've had that covert trauma, there could still be those specific events within that. So sometimes what I'll say is to clients, I only need the chapter, I don't need the book.
Oh.
So just break it down into this specific thing. So this specific time when you saw dad come home drunk and just lose it at mom. So when did that start and when did that one end? And we'll just take them one by one. And generally, most trauma therapists, particularly in the EMDR, are really taught how to do this well, is to set up a trauma treatment plan. And if you treat the first event on the plan and the worst event on the plan, then very often that will generalize to everything else on the plan. And so that's also a lovely way of just being able to keep the process from becoming too overwhelming.
You know, there's several questions, Jane, about finding a skilled trauma therapist. And somebody wrote, I tried EMDR with an experienced, though not skilled trauma therapist, and it was not good at all. I was shamed for being late to an appointment. She became frustrated with me when I didn't get it. Are there trauma therapists who treat specific ages, professions, trauma patients? And then she added, I am so grateful for this webinar. So there's amazing comments in the chat. You have to be sure to look at those.
Thank you. You know, it's so hard. I mean, it's the same as sort of finding a medical doctor. You know, you sort of go and try and find someone who can help you with endometriosis, and you know, good luck. So it is really hard. I think the important thing is, you know, to find somebody that you feel gets you and understands you. And if they don't, you know what, there are a lot of other trauma therapists out there. If you're looking for an EMDR therapist, one of the ways is to find somebody who's actually certified, not just trained, or somebody who has the approved consultant designation, because they've done a lot more hours over and above, and those are supervised hours that they've done over and above just the basic training. And also just looking at somebody's history. So generally when you're looking at therapy listings, for example, on Psychology Today, anyone who's got a big laundry list, you want somebody who's really specific, who really knows what they're doing, and that their trauma modality is their main way of doing therapy, not just something that they pull out of their toolbox every so often. So that's not helpful, but just listen to yourself, get recommendations. You know, word of mouth is the other way to do it.
So somebody else writes, what's a simple way to tell people that you live with trauma? I have children who live with trauma, and many people judge me when I describe their disabilities and their diagnoses. They don't match traditional ADHD. I say they live with trauma, but maybe that's not the best approach as we're working to heal and resolve the reactions within their bodies.
So I think if I'm understanding the question correctly, it's okay to say that we live with trauma, which is where we can say the reaction we're having now might not be about what's going on now. Mm-hmm. And so inviting them to be able to say, oh, is this about this thing right now? Or does this just remind us of this bad thing that happened? And then can we tease that out? Because even if someone is living with the trauma of disability, and certainly being a sibling of that, and just sort of constantly waiting for that, it's about being able to relax and soften in those downtimes, so that we have all the resources we need to be able to get up at the time that we need it. So I sometimes explain it. So if you're driving down a really steep hill and you ride the brakes, and then a deer runs out right at the bottom, you're not going to have anything left in your brakes to be able to not hit that deer. And so the importance of pumping the brakes on the way down, so we don't go, we take it slowly. And in a way, life needs to be like that. It's what are those moments when we are safe, and let's extend those so that we've got all the resources we need for those moments when they're not.
Thank you for that, Jane. So somebody else writes, would love to hear Jane's thoughts on how to help those closest to us with their tendencies for knee-jerk reactions due to their own traumas, especially when they are resistant to recognizing their behavior, and that yet they're leaking their trauma upon those closest to them.
Yeah, it kind of depends who it is and what the nature of your relationship is. One of those ways of just, again, naming it is going, well, this is really scary, isn't it? Sometimes that can be really disarming. So, you know, if instead of sort of responding with, this is completely inappropriate, and, you know, how dare you, you know, it's just like, wow, that's a really big reaction. What's under that for you? And they might get, you know, but it'll end the dynamic. And so instead of everybody tiptoeing around it, once it's named, it's out there, and then it needs to be dealt with.
So somebody else writes, there's shame and stigma related to trauma in healthcare cultures unless it's physical trauma. Do you have some thoughts on how to deactivate the shame and the stigma?
Name it. I name everything. Name it, normalize it. But also, I put it in and I just say, this is the reaction your body should be having. This event was awful. And if you just kind of move on as though it wasn't awful, what are you, Spock?
Mm-hmm.
The reaction you're having is showing me that you're human and that this was an assault on your humanity.
Mm-hmm.
And so let it out. Let's have it. Let's be outraged. Let's be upset about this because this was not okay.
Mm-hmm. You know, Jane, I often think about that during this time of COVID, that I think sometimes there's a perception that healthcare professionals are going to just bounce back. And I think there's a ton of work that people need to do to process their experiences and to get in touch with what their experiences have been. And everybody has a story. And, you know, I was really touched when you were talking about, you know, as a therapist, it's not only helping people with trauma, but it's your own trauma. I've been talking about this time as being one of cumulative losses and collective losses. So individually, all of our losses have accumulated over time, and everybody on the planet is experiencing loss. So it really is such a unique time.
It really is. Yeah. And that's also about just being really kind to ourselves, as well as being kind to others. And unless we take care of ourselves, then the well's going to be dry and we can't do the healing in the world. So yeah, self first. And you know, when we're in this profession, we're all kind of anxiously attached and codependent, and we generally put ourselves last. And we need to turn that around and take care of ourselves, and then learning how to work with the heart space will then just have huge impacts on the world.
So Jane, the last question I want to ask is about post-traumatic growth. You talked about post-traumatic stress, but there's always the opportunity for post-traumatic growth.
Yeah. So I love this. I think Bessel van der Kolk brought that in because, of course, disorder is sitting with the whole medical model, diagnostic and statistical manual, or there's something wrong that we need to name. But yeah, absolutely. If you're going to work through your trauma, you are going to grow through it. And you're going to come out the other side. You're going to learn stuff that you didn't know before. Your body is going to be able to do stuff that you couldn't do before. You can be in the presence of other people's stuff that you couldn't be in the presence of before. We want to just make sure that we don't just bypass to that, though. So bypassing is very easy to do. Just say, oh, I forgive them. I'm fine. This is done. We need to go through the hard work of processing before we can get to that growth piece. But the growth is absolutely on the other side, and it's beautiful.
You know, I think, Jane, of the poet laureate at President Biden's inauguration, and she had an amazing poem. And one of the lines from her poem was, "Even as we grieved, we grew," which I think is, you know, an incredible way to capture this whole idea of post-traumatic growth. Well, I want to first of all thank you, Jane. This was amazing. And truly, if you look at the comments in the chat, you'll see how much people deeply appreciate you being with us today. I also want to celebrate all over the country. People have joined us for this webinar today. And I also want to highlight that we have somebody from Greece, Nigeria, Trinidad, and a few people from our neighbors to the north, Canada. I want to also acknowledge and thank all of the staff at the Bakken Center who helped make today's webinar possible. And I want to remind you that in April, the center will be hosting the 4th International Integrative Nursing Symposium, and this event will be completely online, so you can join us from any place around the world. Visit our website, and there's still time to submit an abstract. So we'd love to hear from you. And we'll be sending you a link to the website for the symposium in the post-event email that Molly talked about. So thank you so much, Jane, and thanks to all of you for joining us today. Have a good rest of the day.